Are we live?
Yes.
Thank you. Good afternoon, everyone. I thank you all for joining us today. We hope you and your families are doing well and staying safe. I would like to welcome you to this webinar hosted by Practo in collaboration with Nat Health, Fortis LaFemme, and VOH. I'm Dr. Ajay Alexander, and I head the medical team at Practo. As frontline healthcare workers across the globe, fighting every day to find solution to combat the outbreak, knowledge sharing becomes more crucial than ever for the entire community. The COVID-19 pandemic has set many new norms for the entire world, with the healthcare industry leading this change. While telemedicine has been around for more than 2 decades, it is now only that it has reached its full potential and it's being accepted, understood, and utilized in India. Technology has made it possible for people to access healthcare without having to travel or risking a potential exposure to any infection. This has changed the way primary healthcare is being delivered now in India. There is a greater acceptance and attention for digital health solutions during this coronavirus crisis, and we believe that the trend will continue even after the pandemic. Doctors have never been more supportive of digital technology than now, and the patients are slowly getting used to telemedicine as a new norm for accepting and accessing healthcare. Did you know 50% of the users have consulted through telemedicine for the first time after the outbreak? The objective of today's Practo Connect webinar is to understand the best ways to implement and leverage the telemedicine practice in India during these times, with a focus on gynecology and obstetrics. I would like to welcome our experts for today and thank them for joining us. We have Dr. Nandita Palashkar, Medical Director, Babies and Us IVF Fertility Center and past President of the Federation of Obstetrics and Gynecological Societies of India. We also have Dr. Pratima Reddy, Director and Senior Consultant, Fortis LaFemme, Bengaluru, Obstetrics and Gynecology. Before we start, let me explain how you can interact with us during the webinar. If you have any questions during the presentation, please write them on the chat. We will also have a Q&A session at the end to answer your queries. We will send you all the relevant links after the event, including a link of the webinar recording. Now let us start with a presentation to understand the evolving role of telemedicine in India. So Practo is India's largest digital healthcare platform. And our vision is to help mankind live healthier and longer lives by simplifying the ways to be healthy. So let us go through the evolution of telemedicine in India. So telemedicine started in the year 2000 with the formal launch of telemedicine in India, and followed in 2001, the ISRO telemedicine pilot project. And we have the other initiatives in 2005, 2009, and in 2018. 2020 has been a big landmark change for telemedicine, where the telemedicine practice guidelines was launched on 25th March of 2020. So this is a screenshot of the telemedicine practice guidelines. You can even see the link here. And this is added as the 5th and Appendix 5 in the Indian Medical Council of Professional Conduct, Etiquette and Ethics Regulation in 2002. So these are the links that is a ready reckoner for you. Other than the guidelines, which was launched on 25th of March 2020, we have frequently asked questions, which was released on 6th of April, and a few modifications to the medicine list and telemedicine practice guidelines on 11th April 2020. So just to take you through some of the important aspects of the telemedicine guidelines is the medical ethics, data privacy, and the confidentiality clause. So it is very important that the patient's personal data should not be disclosed or transferred without the written consent of the patient. And this is guided by the principles of medical ethics, including professional norms for protecting patient privacy and confidentiality as per the Indian Medical Council Act, and it will be binding and must be upheld and practiced at all costs. There is a clause also covered here regarding misconduct. And some of the key points that we need to be very careful about is we should not be sharing any of the personal information of the patients. It could be medical records, images, data, or any other sensitive material to non-relevant people, and especially in social media and etc. We should also be very careful about the prescriptions that we are writing to the patients. There is a restricted list, and it will be considered a misconduct if we prescribe medicines from the restricted list. The other very important thing is we cannot advertise or solicit patients for telemedicine through any advertisements or inducements through social media, newspaper, or any other channels. So this is any of these misconducts will definitely be handled by or will be covered by the IMC Act, ethics, and the other prevailing laws. So this is the other very important thing that we need to be careful about is we need to be well aware of our responsibilities while doing a teleconsult. The RMP may ask the patient to provide relevant information in detail. And it is the responsibility of the patient to ensure this information is shared in full to the RMP. And if the RMP feels that the information provided at any given stage is adequate, if he or she feels inadequate, then he or she shall request for additional information from the patient. This information can be shared via any mode, in person or via email, text, or any of the digital platforms. It is acceptable. But it is very important that the RMP is supposed to be satisfied with whatever the information that the patient has given, and he or she should feel that it is adequate. If the RMP feels that the information is not enough, we can proceed to just give health advice and educate the patient as appropriate, or refer the patient for an in-person consultation. The gist here is do not take any risk. The other important thing is in a telemedicine, patients tend to want to be anonymous, or the doctors would like to be anonymous in the consultation. The telemedicine guideline very clearly calls out that this cannot be anonymous. Both the patient and the doctor should know each other's identity for various reasons, including legal requirements. It is also very important that you take a explicit consent from the patient before you start a teleconsult. If you're using a teleconsultation platform, the teleconsultation platform generally takes care of these requirements. So the very first thing when you need to do when you start a teleconsult is to inform the patient about your name, qualification, and other relevant information such as experience and where you practice and etc. It is also important that the patient also confirms the name, age, address, and any other required information that might be reasonable to identify the patient. So this is very, very important as a physician, that many a times we find that proxies, show up in a teleconsultation platform where the parent is far away, the children are trying to consult for the patient from a different location. The nuances of a certain disease might not be known to the person who is the proxy. So your decision might be impaired or limited because of the lack of information or the wrong information that is being given by the proxy. So it is very, very important that you know who the patient is and you establish the fact that you are speaking to the patient. The next very important information that you need to know is, whenever you do a teleconsultation, there is a very, very important or an urgent need to make sure there is a complete digital trail of the phone logs, email records, chat, text, video interaction logs of the entire conversation. You should also be in a position to store the patient records, reports, documents, images, diagnostic tests, or any other information that is being utilized in a teleconsult should be retained. The most important document that has to be retained during a teleconsult is definitely the prescription, which is being shared to the patient. And please be well aware and well informed that your prescription that you are providing, it should comply with the Drugs and Cosmetic Act of 1940 and the Professional Conduct Guidelines of MCI of 2002, where they have very clearly given the format in which the prescription should be in. In case you are sending the prescription directly to a pharmacy, you should get a consent from the patient before transmitting this prescription to the pharmacy. At the end of the day, as the prescription, in all scenarios, the RMP is responsible for his or her prescription that has been issued. The other most important burning question is, how do we handle an emergency teleconsultation, right? A teleconsultation has its own limitations, and you might not be able to give the adequate care that is possible to a patient. So, but as a first thing, please do not deny any emergency teleconsultation. If possible, with whatever tools or assist which is available, please provide a first aid. If that is not possible to be accomplished, then please do refer the patient to the nearest healthcare facility. So the guideline is very clearly listing this out, that it is designed to provide a balanced approach in such condition, where the RMP is based within his or her professional discretion, might be able to provide an advice for a first aid or counseling, or facilitate a referral in case of an emergency. Now let us come to how teleconsultation has grown in India in the last few years. So we can very clearly see that the chart very clearly sees how the trajectory is, a trajectory of teleconsultation is. And as per the industry leaders, we are expecting a $5.4 billion growth, annual growth, or the potential growth by the year 2025, with a compounded growth of 31%. From 2016-17 till 1920, the year we have seen a 400 to 500% growth. And this is quite significant, especially after March 21, 2020. And this is data coming in from our own Practo's internal data. So we can again here, we can see in the year 17-18, the financial year 18-19 and the year 19-20, we can see how teleconsults have grown, right? And especially I would like to point out gynecology, obstetrics and gynecology is one of the highest growing streams of medicine in the year 1920. We can also see here, this slide is very clearly showing the distribution of teleconsults from metro cities and the tier 2 cities. In the financial year 1920, we can very clearly see when compared to the year 2016-17, the tier 2 cities, the number of consults coming from these cities have grown exponentially, where now the distribution is 60-40, where 60% of the consults are coming from metros and 40% of the consults are coming from tier 2 cities. So to give the overall key insights, we can see that overall the consults grew by 500% in just the last 3 months after the pandemic has started. And 50% of those consulted online are first-time users. There were close to 50% increase in the number of people with more than 60 consulting online. Consults for COVID-related symptoms nearly grew by 200% in the last 3 months. And 20 plus specialties saw an average of 200% growth for teleconsultation just in the last 3 months. So telemedicine is definitely a new frontier in obstetrics and gynecology. So when we specifically look for obstetrics and gynecology, this has been the topmost consulted specialty in the last 3 years. That is 1 in every 3 consults on Practo telemedicine platform are for obstetrics and gynecology. Gynecology has witnessed a year-on-year growth of about 150%. And especially, gynecology has seen a 250% growth since the COVID-19 outbreak. 52% of all gynecology-related consults are from women, and 48% of the queries are from men. So if we break it up to understand the age group and what are the top problems that are being asked in our teleconsult platform, is in the age group of 21 to 30 years, menstrual problems and birth control have been the highest queries. In the age group of 31 to 40, pregnancy complications and miscarriage. 40 years and above, irregular periods and menopause. But after the lockdown, safe pregnancy during the pandemic and sudden irregularity of periods due to stress have been the top trending queries in our online teleconsult platform. To summarize, COVID-19 has enhanced the reliance on telemedicine, and the change is here to stay. The release of India's new telemedicine practice guideline is definitely a welcome step and will widen the scope of remote consultations in India. Makes seeking care easy for stigmatized health conditions and extremely convenient in cases of follow-ups. Helps overcome the obstacles of patients ignoring symptoms or delayed care, especially when people are embarrassed to seek care. So thank you. That ends my presentation, and I would like to request Dr. Nandita Paleshkar to start with her topic on implementing telemedicine practice in India in gynecology.
You have to stop sharing your screen. Yeah, thank you. Hi, I'm Dr. Nandita Palshetkar, and today I would be talking to you. 1 minute. I need to reduce this slightly. No, wait. What has happened? Okay. Share screen. Okay. Just give me 2 minutes, please. I need to reduce this. Okay, now I can see the screen. Hi, everybody. I'm Dr. Nandita Palshetkar. Thank you, Ajay, Dr. Ajay, for that lovely talk, and it really clarified a lot of points. And I'm an infertility specialist. Working for more than 25 years and have been doing a lot of webinars, especially in this field. And being the past president of Foxy, I was part of the Foxy guidelines to create the telemedicine guidelines, etc. So I think today my talk is going to be on telemedicine, what every OBGY should know during the COVID-19, and especially, focusing on infertility, which is my forte. I think Abdul J. Kalam, our favorite president, has told us that technology is a gift to the field of medicine and we should use it for the benefit of mankind. And it's really never proven more true than during this period, especially when, we are all locked out and we are using technology for different things. I just wanted to tell you a few things. Actually, the whole history of telemedicine, it began actually in 1876 with Graham Bell, inventing the telephone. I think that technology really set it off. In 1924, there was actually a book which was written and which says teledactyly. It was a fantasy idea that through the hologram and you could actually see people and talk to people in real time. Of course, the picture phone, which was invented in 1964, was one of the beginning. And then NASA used telemedicine in 74. And the World Wide Web was actually invented in 89. And from then, I think we have not looked back. In 2000, in fact, we had Skype, FaceTime, etc. So where we could do individual, you didn't need to go to satellites to be able to connect, satellite centers to be able to connect to things. And of course, 2010 saw a rapid expansion of telemedicine, and which you've heard Ajay, how he was talking about what it's going to be in India and all. In fact, 2020 is predicted to have a $34 billion share in telemedicine in health. So you can imagine he's talking about 25 in India, but I think we are very much there. And today we need to understand that telemedicine has become a very, very essential part of our lives. And we need to understand that we cannot live without it now. So actually, yes, you have many platforms, but a simple tool for a doctor, which we've been doing right now. I think everybody is handling this, especially triaging at clinics, etc. We are doing this. There's a physician, there's a clinical workstation, there's a patient, a nurse, dietitian, and the telemedicine tools. You can have different monitors, etc., which I'm going to talk about. So we have different tools that are available now. These platforms are definitely available where I think what Ajay said, it's very systematic. You know, the prescriptions are maintained, all the records have to be maintained. So you need that kind of a system. But today, telemedicine can also be done through Skype, through Instagram, through WhatsApp, etc. Each one is creating his own telemedicine tool, each doctor, to communicate with the patients and to see that the patients don't have any problem. And I think this is what the new age doctor is going to look like. I mean, with all the technology and all the technological aids, even now I have to ask my son for help. So I think we are the 50 plus doctors are going to learn to be techno savvy soon, and watch out, younger generation. We are good at what we do. So once we master it, I don't think it should be that difficult. Though I'll never learn typing in my life. There was this study conducted in 2017, and the most common symptoms, as Ajay has shown on his slide, is contraceptive management, then prenatal care, and sexually transmitted services. You know, women or people feel really worried or scared about coming and asking questions about sexually transmitted diseases. And I think telemedicine has provided the best because it creates a kind of a barrier. You don't feel shy about talking, and you can ask questions without any problems to your doctor. And because of the COVID and the telemedicine guidelines, which were released in March 2020, Foxy also had an advisory on telemedicine. And, Dr. Ajay Kumar was saying gynecology has shown the maximum growth, but then 50% of our population is women. Women is gynecology, so it's going to be there. So, and I think what it has shown is that women need a lot of care, need a lot of attention, and the health care of women is so very important. In fact, our government focuses a lot of programs on healthcare for women because women, they are falling short of it. And I think women have been kind of neglected in our country. The woman of the house usually takes care of everybody, and she's the last one who will take care of herself. So I think the telemedicine, and we are seeing a lot of women come forth with problems. The Foxy advisory on telemedicine is the use of telemedicine is now recommended as per the MCI directive, and recourse should be taken to facilitate minimum outpatient attendance. So Foxy has also gone ahead. And I would like to really discuss how telemedicine has helped me in my IVF practice. I think it's been a wonderful thing for IVF, and the patients are traumatized because there were a lot of cases which were being stopped in mid-cycle. Some of them have frozen eggs, some of them have frozen embryos, and they were all worried about what is happening. So all my old patients, it is new patients are also coming, and we are consulting them. But I think the facts which Dr. Ajay said, that you need to identify the patient, you need to have their, consult. So what we are doing is we are using WhatsApp and doing these kind of things, maintaining records and all. But I think a system, which there are so many of them now, should really be helpful to get us into it. And especially, I think Practo has a beautiful system to teleconsult. So our first consult on the teleconsult is when I take the name, the age, the identity is in the name, the identity comes in. So we usually ask the patient to share their Aadhaar card or their PAN card or some kind of official document, and the age is documented, menstrual history, obstetric history, medical history, and surgical history. Any previous fertility treatments are done, their reports are asked. If any investigations are done, those are had a look. Now, everything is through telemedicine, and what we do is we advise the patient investigations. So a consult is sent with the list of investigations. So basic investigations like, CBC, LFT, RFT, etc. And hormonal tests, I generally prefer an EMH for my infertile patients, and thyroid and prolactin. and an ultrasound pelvis. Now remember, an ultrasound units are operating else around, and it would really be good if the patient has an ultrasound and a semen analysis, of course, for the husband, because then we can come to a diagnosis and we can tell the patient what to do. The follow-up consult is follow-up with the reports, the triage questionnaire. Now, supposing I advise the patient IUI, or I advise the patient IVF, or I advise the patient, have like anovulatory patients like PCOS. You can do ovulation induction and then have a planned intercourse. That can be done at home with checking for ovulation, the ovulation test kits. So all these kind of tools need to be used now to be able to treat the patient. So that if I'm doing an IUI or an IVF, I do a triage questionnaire 2 weeks. The next slide is the questionnaire. And this is a questionnaire which is done prior to the treatment being initiated, or even prior to the visit of the patient. Sometimes you do need visits. And pre-medication is something that I start during the waiting period. If the vitamin D is low, B12, if the thyroid is going up and down, it's not normal, we do a teleconsult with an endocrinologist and start that. Then for poor responders, something called ovarian tonics can be started. A metformin or a myoinositol can be started for patients with PCOD. So I think these are all the way in which you can, pre-medicate the patient and get her to a fitness level before you start. So this is the triage questionnaire, which is, of course, I must say courtesy thanks to Eshre. And these are 13 questions which the patient answers. Have you been sick in the last 2 weeks? Do you have fever over 37.5? Are you coughing? Do you have a sore throat? Have you lost your sense of smell or taste? Have you been in contact with somebody who has any of these symptoms? Have you traveled to an area nationally or internationally? Do you work in a hospital, nursing home, or healthcare facility? Have you been in contact with somebody who has COVID-19? Have you been diagnosed with COVID-19? Do you live in a household with somebody who has these symptoms? If you've been COVID positive and recovered, do you have certified medical evidence of clearance? And do you have comorbidities like diabetes, respiratory disease, hypertension, etc.? I think this triage questionnaire is very, very important before you take any patient for IVF. And once the patient has answered the triage questionnaire, we have two scenarios, scenario 1 and scenario 2. So scenario 1 is when the patient and the partner is asymptomatic, the triage is negative. So this is actually done with telemedicine consultation. So you confirm that the patient is negative. Now this questionnaire has to be answered 2 weeks before, 1 week later, and again on the day the patient is coming to meet you in the clinic. And these are the patients who will pass this scenario and will be included. So you can do either IUI for them, you can do IVF for them. So these are the options that we have for them. And even if you're planning a laparoscopy, I think you can go ahead and do it once the patient has been triaged and has seen you. And of course, the scenario 2 is if the triage is negative, they're positive, then obviously you have to wait, you have to cancel them from your cycles and not include them for your IVF treatment. So treatment protocols, so when patients come, you should give this all over your teleconsulting. That the patient must wear masks when coming to hospital. If it's an IUI, we need only 2 visits of sonography. If it's IVF, 3 to 4 visits only for sonography. So in IUI, we do a day 8 and a day 12 visit. In IVF, we do a day 7 or a day 8 and a day 13 and maybe a day 2 also. Patients have to take appointments before coming to the clinic. Each patient is called at 20 to 30 minutes interval, and the waiting area is prepped in such a manner that the seating is minimum 6 feet. So all these things have to be taken care of when you're doing teleconsulting and you're going to start your treatment in your patients. And most of the cities now have allowed it, and I think this is what we should do. Manage most of your patients on the teleconsult and have minimum visits to the hospital. Even for treatments, you can do it. All reports and papers should be via the mail, WhatsApp, or any other teleconsultation tool. No need of a file at all. Doctor also puts it, you enter it in your computer, or you can write it on a new paper, take a picture and send it to the patient if you're using WhatsApp. All patients have to sanitize their hands prior to entering the OPD. And all procedures like IUI or ovum pickup or embryo transfer, there should be a gap of 45 minutes to 1 hour. So we are giving triggers at 1.5 hours interval. So that is what you must do. And I know there are a lot of people who do batch IVF, but they will have to change their way of thinking and do it differently. Maintain a digital trial or documentation of consultation. It is very, very important. I think Dr. Ajay has stressed on that also. So you have to maintain your records and documentation. So log or record of telemedicine interaction, patients' records, reports, documents, images, diagnostics, digital or non-digital, utilized in the consultation should be retained by the doctor. Specifically in case a prescription is shared, we have to maintain the prescription in our records. It's the same thing what you would do in a physical consultation. We have to do it. Also, the fee for telemedicine consultations should be treated in the same way as in-person consultations from a fee perspective. The doctor can charge an appropriate fee for the telemedicine consultation provided. And I think this is very important to understand, that it has been permitted to charge and you can charge it. And also, remember, you should give your receipt, because the IT will otherwise then come asking you for it. So what are the advantages of telehealth? You can reduce the burden of travel. I think, some of my patients used to wait for 2 to 3 hours in the OPD. They would rather have something at a schedule where it's convenient to them. It's convenient to the doctor. You don't have to travel. You don't have to find parking space in Bombay. I think all those headaches are done, and the waiting time is definitely reduced. So improves access for people with even rural and remote areas. I think that's what Dr. Ajay has been talking. That tier C, tier B cities are accessing healthcare via telemedicine from the big cities, and also not only patients. I think it's a lot of connect between the doctors. A lot of times we connect with our colleagues elsewhere and we discuss treatments. If there's a problem patient, I think it's very good even for doctors itself also. So it reduces accommodation and parking costs for the patient, improves access for people in rural or remote areas. It reduces stress, of course, reduces waiting time. So what are the different things? In this COVID era, what I have been really handling patients is, of course, pregnancies, IVF, infertility consultations, old and new patients. Then, a lot of abortion cases. I think comprehensive abortion care is a must in our country, and women have been happy to access abortion care with telemedicine. And the other thing that I have really seen is a lot of stress. I think mental health is also very important, and we've been actually talking like therapists, but I have referred a lot of patients to my psychiatric friends and for therapy, and it has helped a lot of patients. So use of telehealth to access mental health services, cancer services, rehabilitation services, after hours GP support, burn support, and of course our gynecology. I think it's a wonderful tool to help us, and we must use it more. There was this study which was conducted some time ago in US, because, okay, we doctors are very happy with it, but what about the patients? And actually, it was quite surprising. 55% were uncomfortable conducting a doctor's appointment through telemedicine. Only 35% actually chose virtual appointment. But this has now changed. Imagine in America, there were people like this. But even in India, now people have changed because of the COVID. They would rather not expose themselves. And a lot of people, if we conducted today this kind of a survey, I'm sure we'd have a lot more patients who would want, telemedicine. To go back to the survey, of course, 75% would actually trust a virtual diagnosis less than an actual visit. 63% would like to do it from home. Very few, said just 7.5% said they would like to do it from a kiosk. 51% said that if there is more scheduling and the cost is reduced, definitely they would go for telemedicine because it would help them save money. And 65% actually said that it helps if they met a doctor first. Before first visit should be a physical visit, and then they wouldn't mind a telemedicine consult. And this is what I've been seeing over the last couple of weeks, that definitely patients who have met me before are coming in. But there has been a rise in the first consultations also, and they're pretty happy. Although some of them prefer a video consult, and I think that's fine. I think you like to put a face to the speaker, to the doctor, and I think that's really, really important. So friends, I would like to conclude by saying that today telemedicine can be used in many settings. Provider to provider consultation. As I said, in IVF, I'm using it to give my patients the benefit of my expertise and for starting treatments. Provider to patient consultation. Provider to provider, meaning other doctors who ask, like we are having this kind of a webinar today, where you'll probably have questions and we would be able to answer those. I think that kind of a consultation. Then ultrasound or fetal echogram. Now, these can actually be done in the setting, and these images can be transferred. In fact, my friend in America, who is a radiologist, she sits at home while the radiology technician gets all the pictures and sends it to her to read. In fact, at times she's even real time on it, and if she doesn't, she wants a different plane, she will actually call him up and tell him, just get me this plane. So I think ultrasound and fetal echocardiogram is going to move in that direction. Then antenatal testing. I think Pratima is going to talk about it, so I really don't want to talk about it, but it's an amazing tool for antenatal consultation and remote patient monitoring, blood pressure checks, diabetic management, etc. It's very, very good. And in fact, there are now monitors to even monitor the uterine contractions during pregnancy. Then postpartum treatment like depression, weight loss, follow-up, etc. Research and patient education. And I think I would really like to add here the reproductive health services like contraception, abortion care, etc. And especially in disaster relief and hurricanes and pandemics, I think telemedicine has proved very, very important, very, very crucial. And especially now, we have in Bangalore, I think, they have a system where the robot goes and distributes the medicine. But in NSCI Dome and in the race course, we have created beds and everything is monitored by the telemedicine. Now look at the ICUs, they're all monitored by telemedicine. So in fact, unless the patient requires some intervention, you don't even need to go near the patient because everything can be monitored. And especially in a situation like this where healthcare falls short of providing for everybody, I think telemedicine would really take this burden away from the doctors. So thank you very much. And I would like to conclude by saying, in this era, be kind, be empathetic, be patient, and don't forget to take consents, maintain records. In fact, consents are of two types. One where the patient actually seeks the telemedicine, and the other is when you have called him to consult him. So it's very, when the patient calls you for a consult, it's it's known that he's consenting to do it. But when you are calling up the patient and you have suggested telemedicine, I think it's very, very important to take the consent from the patient. And I think I just want to say that stay home. I don't want to say that now because I think most of the lockdown is opening and it's 1.0. And of course, we need to get out there and be with our patients and start treatments. But definitely stay strong, stay safe, and stay healthy. Thank you. Thank you very much.
Thank you, Dr. Nandita, for this wonderful insight. Now I request Dr. Pratima Reddy to take us through implementing telemedicine practice in India in obstetrics.
Thank you, Ajay, and thank you, Nandita, for those two really insightful talks. I think both of you have convinced the rest of the community that the time has come for us doctors to start working from home as well, instead of expending ourselves in hospital. Just give me a moment while I share my slides, please. And you're right, Nandita. Yes, there are robos sort of moving around very effectively in none other than our premier institution of the government, Victoria Hospital.
Yes.
Yeah. So
I think I'm at home, Pratima. You're at work.
Yeah.
I know.
I'm at home, yes.
Yes.
Just to introduce myself, I'm Pratima Reddy, gynecologist and obstetrician practicing in Bengaluru, the director and senior obstetrician at Fortis La Farm Hospital. We are now 5 years old. We opened up as a women and child institution and a multi-specialty institution at that. So we have various specialties, not just birthing and gynecology. So about 4 months ago, you'd all be forgiven if you thought that this was a scene from one of the busy railway stations in this country. But actually, it's a very busy outpatient department in one of the premier institutions in the north. And as you can see, people there are jostling for space, literally tummy to tummy, as you can see, and breathing air amongst themselves and upon themselves and everybody else. But then COVID happened. And now, this is what an outpatient department can look like. Very few people, very few patients wearing masks, spaced out 6 feet or more apart, staff, which most of them have been asked to stay at home, and very few doctors per day. Of course, these are difficult times. These are pandemic times, and this is how hospitals, clinics world over are coping with, by keeping people at home. Patients themselves have fled from hospitals. Staff and doctors are worried about coming into hospitals and exposing themselves to COVID. So you've heard both my colleagues talk about telemedicine in India, and whether implementing telemedicine in India is really a practical thing, whether it can happen given the vastness and the variety of this country. Of course, we all know that Indians probably are the ones in this world who seem to have the most number of mobile phones anywhere. So perhaps that is a starting point for us to be able to deliver healthcare to women and children in this country.
Dr.
So what are the
Pratima,
challenges?
Dr. Pratima, I think your slides are not changing.
Oh, okay. I'm sorry about that.
Yeah, we are still on the first slide.
Apologies, apologies. Just looking into it, Ajay. I think we've frozen a bit here for some reason. Has it changed now, Ajay?
No. Have you gone to slideshow? Just go to slideshow and play, or at the bottom of your screen there will be, or you can play the slideshow.
Can you see it now?
Yes.
Yep.
Now, this is the second slide of yours, I think, with a lot of people in the OPD in the north before. So you can go ahead now.
Sure. Okay, so going back to what I said quickly and briefly, I'll just recap that. Thanks for telling me that, Ajay and Nandita. So this is not a railway station. This was what it was 4 months ago. in some of the big government hospitals in this country, and then it all changed. Nandita and Ajay, still on? Can you see the new slide?
Yes, yes, you're doing it perfect now.
Thank you. There you go. You can see who's the one challenged in this telemedicine thing. So back to this, 6 feet apart, masks on, people have fled from these hospitals. They don't want to come in, as Nandita said. They'd rather sit at home in the comfort and the safety, and that's the thing these days, the safety of their own homes before they come and expose themselves to us. So is it practical in this country of 1.3 billion plus, with a variety of women and men, will it be possible to deliver telemedicine to all these women in all the most remotest corners of this country? And as I was saying, one of the advantages is that we seem to be the country with the most number of mobile phones. So yes, it should to a large extent be deliverable. So what are the concerns? Well, concerns for us doctors and healthcare workers, we have to get into all this paraphernalia, perhaps not this much in the outpatients, but you still have to take care. And each evening when you go home, you're worried about taking home the infection to your near ones. The iconic Amul girl herself said, well, work from home. And if you think back to those days when we were medical students and doctors, you always thought to yourself, well, you know what? I think my colleagues who worked in the IT professions, they're probably doing much better. They can work from home, whereas I have to go into hospital every single day and have no absolute hours of coming in or going out. So what were the questions that needed answers before we started off on this? Is it legal? And as you heard both Nandita and Ajay say this, yes, it is. It is legal and you can practice telemedicine well within the pointers and the guidelines that have been laid out for us. And that is important to emphasize. That is important to emphasize. Do I have to maintain records? And this is the third time we're saying this. Yes, you do have to maintain records and make sure, please, that these records are kept for posterity, just like you do at hospital. Would it help all categories of women? And we hope that it will help all categories of women. By categories, I mean all socioeconomic strata. It should help them, we hope, over time, as soon as and as long as people get into this mode of telemedicine. What do I do in an emergency? And in obstetrics, there are two lives at stake, both the mother and the child. So yes, in an emergency, as both my speakers have already said, talk to the lady, talk to her attender, tell them what is required, and at all times encourage them to seek care at the nearest hospital or come into your own hospital if that is the closest. Can I end a consult if I'm not comfortable? Yes, you can. You have a right to end a consult if you are not comfortable. What if the patient calls at inconvenient hours? 3 o'clock in the morning, you get a call. You don't have to take it. You're not obliged to take it. And of course, very, very important, will I be paid as I'm paid for my outpatient consults? Yes, you will be paid for this. But as Nandita said, please make sure that you give them appropriate receipts. So what then are the guidelines that we have on how to manage pregnant women via telemedicine? So previously, we saw them quite frequently. So are these there for all of us to follow, or is it just an individual thing that we're all doing? The maternal fetal medicine guidance on COVID-19 was put out by the ECOG, and there have been other bodies as well, including FOGSI, which tells us how frequently we need to see them. And there are a few variations on this. I'll just move on to my next slide. Again, a few weeks here and there. And I'll move on to what I practice or I have been practicing in the past few months. So the first visit would be a teleconsult. And again, identify yourself, identify the patient, make sure that you have all the records with you or whatever records they have provided. I'm talking about obstetrics. and take down the history as you would take down a history at your outpatient clinic. So what I tend to do is get all the stationery from the hospital, actually take this down and maintain those records and put that into the file once the patient attends the outpatient, whenever that may be, and continue to maintain records if the next few consults are teleconsults before they come and see us in the outpatient clinic. So the first visit typically in a low-risk pregnant woman would be a teleconsult. And post that, the second visit ideally would be between the 11th and the 13th week. This would be the time to introduce yourself face-to-face, reiterate to her about what are the precautions she's got to take in COVID times, especially given that we have a pandemic going on. And of course, all the blood tests, scans, etc., can be arranged at this one visit, making sure that this visit is a one-stop visit for her. At this time, again, go through your history, make sure that you have not missed anything that you took in the first visit itself. It is an opportunity as well to be possibly able to connect with the attender via telephone or WhatsApp if you've not been able to do that in the first visit, which is the televisit. 2 weeks later is when I get them to come on to a clinic appointment. I'm sorry, 2 weeks later is when I ask them to come on to a tele appointment, when I would review their blood tests and the double screening or the quadruple screening, as the case may be. This is also the visit that we talk about their diet and exercise and look into any other problems that may have developed between the 2 weeks that we have seen them. So the next clinic visit would be at the 5th month, between 18 and 20 weeks, when we also get them to get their scans done and have another consult about any problems that they may have had. Now, in all these weeks, the other thing that they're advised to do is to basically check their blood pressures, check their weight, and also make sure that if they do not have access to a digital blood pressure apparatus, not to go to the nearest clinic, especially in the present condition, and have their blood pressures checked if there are a few other sick people waiting. And I think this is important to emphasize, because when we ask women if they have a BP apparatus at home, they'll say, no, doctor, we'll go to the next clinic and get it checked. And I don't think that is an option. Not everybody can afford a blood pressure apparatus, which is fine. But certainly we would not want them to go to other hospitals or other clinics in the present pandemic. So the 24th week visit could be a teleconsult, where again, we check with them about baby's movements, because by now movements would be felt by the mother. We also check about her weight. If she doesn't have a weighing machine, could she buy one? Possible. Blood pressure, could it be checked? If not, make sure that this is a low-risk woman without any risk factors for developing preeclampsia. Again, the GTT test should be done at the 11th to 13th week, so that you know early on, or even earlier, if she visits you in hospital, so that we know early on that she does not have any gestational diabetes. One of the concerns in this country is that these women can develop preeclampsia while we do not see them and check their blood pressures. And that is something that we have to safeguard. So the 28 weeks would be the one to the hospital, where you get her blood tests and do a scan if required, depending on the risk profile. The 30 and the 30 weeks could be as teleconsults, where again, you ask them routine questions, make sure they're healthy. The 32nd and the 36th week could be hospital visits, where you do your blood tests and a scan at the 32nd week to be done if it was not done at the 28th week. And this would be an ideal time just to do a one-off growth scan. Between 37 and 40 weeks, I see them once in a week or once in about 10 days. And this is, again, just to make sure nothing has developed late in the pregnancy, and also to make decisions about delivery also to prime them about when to come into hospital in the last few weeks of the pregnancy. So, coming to gynecological problems, what were the gynecological problems that women contacted us with via telemedicine in the past 2 months when telemedicine began in a big way? There were a number of women who had abnormal uterine bleeding. And again, remember, most of these women contacted us simply because they could not put up with the heavy bleeding anymore. In fact, the gynecological problems that we had over telemedicine were not as many as the pregnant women who were consulting us. There were quite a few who wanted preconceptual advice. The women with white discharge, itching had actually come down quite drastically, never mind that we see them so frequently in our clinics. Somehow it just had disappeared, or they had decided to put up with it rather than talk about it or come to hospital. There were women with pain abdomen, but a lot of these women with pain abdomen was so acute that they had to come into the emergency room anyway. The women with polycystic ovaries, again, were in fair numbers who wanted advice on what to do about their diet, their exercise, and all the symptoms of polycystic ovaries, such as acne, irregular periods, etc. There were fair numbers who wanted advice on fertility problems, that they could not conceive, and what were they supposed to do during this period. We had a couple of women who sought advice about prolapses, and of course, the cancers were the follow-ups. Obviously, we did not have any women who were diagnosed with cancers who came up on teleconsult because they were not seen in person. So, for many of us, I'd say this is uncharted waters. And how do we deal with this? How do we make sure that we don't make mistakes? How do we make sure that we behave appropriately? And how do we make sure that at the end of this all, we keep our patients safe and we keep ourselves safe? So make sure that you keep everything ready before you start off. It's never nice sort of scrambling around, trying to get things, not looking at your screens if it is a video consult. It's okay if you're not on video, but it certainly matters if you're on video. So basically, what is it that you need? Make sure, as we've discussed, you've got your prescription pads. You've also got all the note paper and the stationery that you need in order to take this consultation forward, all the Wi-Fi equipment, a proper spot in your house or hospital, wherever it may be, that provides you with adequate and good, strong Wi-Fi, because that is very important. As we all know, it comes and goes sometimes. All the equipment that you need. Sometimes it may just be a good thought to use headphones and a microphone, because then if you don't have much privacy, the other people at your hospital or your home cannot listen to what the patient is saying. As we said, retain screenshots, email records, prescription records. Remember to affix your registration number on all your prescriptions. That is very, very important. Remain professional at all times, which most of us are anyway. And importantly, keep your phone on silent. What is it that we should not be doing? Don't dress inappropriately. Make sure that you are dressed appropriately for the occasion, because at the end of the day, it is a professional consult. You are a professional, never mind it's a virtual or a teleconsult, you still are a professional, and this is a professional consult. And I think that is very important. The other thing that seems to happen sometimes is, if you're at home or even in the hospital, there are people moving about and in the background which can distract you, which can also take away from a sense of confidentiality for the patient who's consulting you. And I think this is extremely important to bear in mind whenever you're consulting with patients. Don't have any kind of noise in the background. I'm not talking about music, of course, but there are times, I mean, this is India, India is noisy. There are times when there is a lot of noise in the background. which may not always be possible to mute. Don't avoid eye contact and don't do other things. So make sure that you are looking at your patient most of the time and try not to sort of look at your messages or look at your WhatsApp or look at other things and do 3 things simultaneously. Because again, this takes away from the sanctity of a consult. And of course, most importantly, don't touch your nose, eyes, and face, because we all can do that. We all do it. And I think in this day and age, it is extremely important to set an example and make sure that we are not doing it, just as we would tell our patients not to do it. I'm sorry. What do I do now? So, sorry about that. Telemedicine at Fortis La Farm. How did this begin? Well, obviously, it began with the pandemic. Until then, we did not participate in any kind of telemedicine. So all consultants in the hospital, and remember I said that we are a multi-specialty hospital for women and children, were encouraged to participate. So basically, we have an endocrinologist who deals with the gestational diabetics, with the thyroids. She went on telemedicine. We also have the psychologist, the psychiatrist, the dietitian. So all these people were encouraged to participate in this whole journey of telemedicine, including, of course, the physicians, the surgeons, so that the women were basically helped as they were previously. We were given regular training sessions in the use of technology to make sure that we were fairly au fait with things when we got onto it. And when things didn't go well, there was constant IT and phone support at all times from the hospital. Patients were also requested, especially the ones who were patients of ours from the beginning, who were old patients, were requested to forward their case files and records via email prior to each consult, so that we were aware of their previous case histories and we were able to support them better at the teleconsults. Now, in the event of inability to connect, calls were placed via the hospital landline. And of course, there was no video to this, but at least there was a connect with the patients, and patients were not frustrated that because of issues with connectivity and the Wi-Fi at a particular place, whether that was at home, hospital, or their own homes, they were able to connect with us. And in each consult, as already mentioned, it was recorded either by way of notes, email, or the file option in the provider that we were using, and the patient was sent a copy of the same whenever it was possible. So what were the challenges? One of the challenges was internet connectivity from both sides, both from the doctor's side and from the patient side. There were times when we couldn't hear them well or see them well and they couldn't hear us. We found also that patients were a bit confused about which information to send us via email, and it took them some time. Sometimes you just have pages and pages of information which didn't mean anything, and the most important one was not there. So we had to actually either telephone them or mail them and request them to send us relevant information. What about patient satisfaction? Were they really satisfied with this? I think, as Nandita said, in this day and age, unfortunately, both the patients and the doctors do not have much of a choice. And indeed, I think as doctors, we have realized this is a very good platform, which I hope will continue into the future, where you can actually see patients virtually, talk to them, speak to them about their reports, results, and not necessarily have to bring them into hospital with all its hassle, whether there is a pandemic or not. And I think most patients were satisfied. Of course, we had the odd one who felt that she had spoken to me only for 5 minutes and therefore she wanted her money back. But then you can't win everybody. Can there be misdiagnosis? Yes, sometimes, unfortunately, this can happen. And this is why it is so important to be careful and a bit wary, especially with the knowledge that things such as GDM and, more importantly, preeclampsia is a problem in this country and can easily be missed if you do not see them regularly, especially for blood pressure monitoring. The other things were, obviously, because appointments were sort of being given and we were deciding who could come in, who could not come in. We had to deal with the OPD appointments along with our very efficient staff, of course, ourselves. But this was all a learning curve, and it was all in the challenge of dealing with something new. There was also the inconvenience that in the middle of a consult, you would have to go and attend a delivery. But patients were very understanding and patient. And I think the patience and the understanding was heightened simply because they were sitting at home and not sitting in a hospital outpatient department. And from a personal point of view, I found sitting for about 2 or 3 hours a bit boring. But then, given the fact that it helped me deliver medicine this way, it was okay because one is so used to moving about all the time. So I'd like to end with this from A Tale of Two Cities. And I think it's very relevant to what we are going through now. It is indeed the best and the worst of times, but I'm sure soon there will be a spring of hope. Thank you very much.
Thank you, Dr. Nandita and Dr. Pramita for this session.
That's Swati.
Yes, yes, doctor. I'm sure that our doctors would have found it information, and we already have a few questions from our doctors. So the first question is from Dr. Sabrish Nair. The question goes, what are some recent changes to telemedicine from a regulatory and legislative lens, which will accelerate widespread adoption of telemedicine in India? So before March 2020, telemedicine was in the gray zone, right? There was no legislative support from the government. There were no rules and regulations. There was no guidance on how we can practice and what needs to be done. So the biggest adoption, there was definitely a need from the patient side, but many of the doctors were not adopting telemedicine as a route for giving out treatment or healthcare because they were not sure how the government would respond, what are the boundaries for us to practice in. Now we have a set guideline and a framework, and definitely if we can operate within these guidelines with very good understanding, definitely the adoption will go up. So next question we have is from Dr. Evelyn Emmanuel. How to go about reaching to most number of people in rural parts of India? Unfortunately, doctor, the medical ethics does not allow us to advertise as an individual doctor. That would be a violation of medical ethics. But this, as an individual practitioner, this is going to spread through word of mouth, the availability and the connectivity, especially in the days after Geo has come. At a very low cost, even the rural community is able to afford a smartphone with very good internet. And this has definitely seen a spike in the adoption of internet or mobile internet connectivity. So right now, the telemedicine companies are reaching out to via various media to the general public. So I believe this is the only way to go at the moment for individual practitioners, but definitely you can be part of the various telemedicine platforms which are currently operating in India, and they will be able to take it forward for you. The third.
Ajay, can
Yes.
I just interrupt here?
Yes.
I think there are a lot of organizations like Foxy, different organizations like Bangalore Society, etc., who are actually going into rural, and a lot of NGOs. You know, yes. Especially the ones involved in comprehensive abortion care, they have programs with the ASHA workers, yes. And they are completely connected. Like we have in Dharavi, Apnale is the program, and they have given things to the ASHA workers and the rural population. I mean, not rural, the lesser population. And even in rural areas, the ASHA workers actually have programs which everybody watches together and all. So the government is doing a lot of things to reach the last mile, as they call it. And
Yes,
even
doctor.
organizations have it.
Yes, doctor.
Organizations like us are going out to reach the rural areas.
Yes, doctor. So, just to reiterate, as an individual doctor, we might not be able to do much, but organizations, from the government point of view, and the various, associations like FOGSI, they are definitely doing a lot of work, and that is where, how we can reach the rural parts of India. So the last question that we have is, do you think telemedicine should be an integral part of the course in medical schools today? Yes, doctor, definitely we have a requirement of telemedicine to be part of the course, especially, which takes care of how do we handle um, you know so adding to the previous discussion here, definitely we see patient satisfaction to be a very important component in medicine. In the current curriculum that we have, takes care of more of how to manage a patient in a medical point of view. But when we have a communication requirement also as an integral part in telemedicine, right? Patient perception comes into a very big uh, plays a very big part here, right? A patient satisfaction, like for example, when doctor was saying that the patients ahead of the consult can send documents for reference and etc. Now, if that happens, as a doctor, we can literally come to a diagnosis and start giving them a prescription to the patient. This will create a kind of perception from the patient that the doctor did not ask enough number of questions from me to understand what my problems are. As many a times as clinicians, we might come to or arrive at a diagnosis for the patient. So this becomes a perception issue. So we need to have multiple trainings. One, how to do how to do proper history taking, how to do the documentation, how to communicate with the patient. Like, doctor had suggested, have eye contact, don't look around, all these, there are so many components to it. And definitely this will play a major role in our telemedicine guidelines. And it should be part of the curriculum.
Ajay, if I may add,
Yes, doctor.
in fact, the MCI has said that you will need to complete an online course
Yes.
going forward, whenever that
Yes.
may be,
Yes.
and then take it forward if you were to do telemedicine.
Yes, doctor. So at the moment, the Board of Governors have given a timeline of 3 years to complete a telemedicine course and certify yourself to be a full-time or a telemedicine practitioner. But I think the process would be much faster if it goes into the curriculum itself, as into the medical curriculum, where this is becoming a part and parcel of the future healthcare processes. Right, that's the most ideal way to go. This is more for the legacy doctors who have already passed out, right? That will cover for the older generation of
I
doctors who
think
have already.
what he suggested is very good if it's there, but the curriculum today has a lot of virtual classrooms, etc.
Yeah.
So I'm sure they're integrating it into the curriculum now, and it will become a norm, especially with the COVID not going anywhere. So the children are being taught online classes and stuff like that. And in fact, abroad, they have actors playing, they don't have patients, but they have actors who are trained to perform a certain diseases, and the students actually check them and ask them questions. So I think it's going to be all converted into virtual training. They have simulation labs in most of the schools now. A lot of schools have simulation labs, teach them different surgeries, etc. So I think telemedicine is a part of our lives. It's just that we need that tag, like look at me and Dr. Pratima. We've never been trained, but we're doing it now. So I think it's just that we need that certification, Pratima. That's all that we need to actually check out. And, we had started actually when I first started practicing at LAFM Delhi, Pratima, we had done video consultation with Delhi. And the patient used to sit in Delhi and we used to be talking. So I think it's part and parcel. I think they will need certificates for the younger generation. I hope, Ajay, they don't put me through a course to give the exam and pass off. I'm sure I'll fail miserably.
Yes, doctor, I do believe, but at some point of time, we need to look at standardization of, how we do an online consult, right?
So it'll have to
Definitely,
be
this
in
is
the
the point,
curriculum.
right?
How
So
are you
that
going to standardize old fogies like us?
understood. I think moving forward to the next concern or the question that doctors raised regarding case with regards to Dr. Deepa Pavaskar and versus the state of Maharashtra. I think we are not legal people to take up this. I think we should. I think that should be taken up in a different forum. But to continue with this, there is a question about how can we assure patients that they will get medicines from the stores, especially in rural parts after a teleconsult. Um, so one of the things that in teleconsult is as the uh, medical ethics guidelines also suggest, let us always try to stick to generic names rather than brand names, which makes it a little bit more easier for the patients to obtain these medicines even in the rural parts of India, right? That is one suggestion that we can put in play in our day-to-day practice. But with regards to specialized drugs, definitely there will be an issue, which is a current issue either way. Even if you go to for an in-clinic visit also, specialized drugs definitely will be a problem in rural parts of India. So that has to be taken into account, and the kind of drugs that we prescribe has to be in line with availability also. As clinicians, we have to ensure that we speak and understand where the patient is before we give out a prescription. That's my point of view. Dr. Pratima, and would you like to comment on this, or Dr. Nandita?
Yeah, I'd agree with you. I'd
Yes.
agree with you about what you've said, Ajay. Yeah.
Yes, doctor. So I think that ends the questions that have been raised in this forum. And I once again thank all the participants for sparing some time to be here and showing interest in this topic, which is a very important issue and a burning requirement for the healthcare requirements for the Indian citizens. Also, I just would like to inform our participants that you will receive a survey asking for the feedback on the event. Your insights will help us to improve um, our future events,
Yes.
right? And we will also be sending out a link of this recording that you can see or share in your social network. Doctors, would you also want to comment anything here?
I think everything we've enjoyed, we've really been a fun part of, and listening to each other. I think I got a lot of points from Pratima and from you also.
Thank you,
And it
doctor.
was great interacting with both of you.
Yeah, I think it's also heartening to know, Nandita and Ajay, that telemedicine is here to stay.
Yeah.
Yes, doctor.
I think, like you said very correctly, things like parking, stay sitting around for so many hours, waiting for 2 to 3 hours, and then seeing us exactly for 5 minutes. I'm sure, Nandita, well, it may not be 5 minutes with you because you guys have to counsel so much more. But it seems like such a cheated job that you waited for 3 hours and you can see this doctor for just maybe 5, 10 minutes, and then that's it. So I
Yes.
think now the comfort of your own home, where you can call the shots and we can also accommodate them. I think it's a win-win situation for all in most situations. And I think we should take this forward. Yeah.
Yes, doctor. So the other thing is the continuity of care is very accessible and very easy now,
Yeah.
right? Many of the patients drop off from their treatment cycle just because they're not able to access the doctor uh, due to appointment or due to time or distance or money or whatever reason. I think that is the biggest barrier that has been removed. We believe that the quality of life would significantly improve when this barrier is removed, right? So I think we should um, encourage all physicians to be, at least part of their daily practice to be moved to teleconsults, right, or telemedicine, which will help both the patients as well as see more patients in a limited amount of time, right, and ensure that the patient is getting the best quality of care.
Absolutely.
Yes. Yes, doctor, wonderful. Thank you. I thank both the doctors in the panel here for spending time here and all the participants for being part of this event. And on behalf of the entire team at Practo, we thank you for joining us today. And we hope you found this information and dialogue valuable in fighting this battle. And I believe that all of us together can win this battle of COVID-19 and going forward. Thank you.
Thank you.
Yes, thank you. With this, I'm